So good evening, everybody. As we all know that every month we have been focusing on one important cause of stillbirth and trying to create awareness about it. And we have, dedicated webinars on this. So this time we have the Committee for Study of Stillbirths from Hypertensive Disorders of Pregnancy and Renal Diseases. And it's my pleasure to introduce the committee to you all. And we have Dr. Anjoo Agarwal. She's a professor at the prestigious KGMU, and she's done a lot of work on biomarkers for early detection so that we can prevent mortality and morbidity from hypertensive disease of pregnancy. She's a professor there at the Department of Obs and Gynae. She's interested in infertility and high-risk pregnancy and master trainer for SIFSA related programs, and also trainer of trainers for EMOC and RRTC. She's an Ayyoo counselor for PGDMCH course and member of the curriculum committee and team member for SIMNOC and BMOC revision group. The secretary for this committee is Dr. Inas Mushtaq. She's MBBS, MD gold medalist. She's an assistant professor in the Department for Obs and Gynae, Himalayan Institute of Medical Sciences, SRHU, Dehradun. We have some very active and important members. Professor Seema Malhotra from KGMU, Dr. Renu Singh, she's also a professor at KGMU, Dr. Mukta Agarwal, she's a professor at prestigious AIMS Patna. We have Dr. Mona Asnani again from KGMU, and Dr. Amna Qureshi from Jain Medical College, Aligarh. So Dr. Nusrat has not been able to join today because there's some obstetric emergency that she's attending to. And it's my very, very, very proud pleasure to introduce Dr. Sarosh Rana, who's a professor at the University of Chicago. She's MD, MPH, and has been trained at prestigious institutes and including Harvard. She's an analyst from Jain Medical College. I'm extremely proud of that. She's a professor and in charge of the fetal medicine section, University of Chicago. She's an expert in the diagnosis and management of preeclampsia, also serves as a mentor on various clinical, basic science and translational research projects. These mentored research projects have resulted in multiple national and international conference presentations and published manuscripts. She has over 100 publications in reputed journals focused on pathogenesis of preeclampsia. And I'm very proud to tell you all that she's part of various international guidelines, and she has her own dedicated lab for research, the Rana Preeclampsia Lab, with long-term goal to contribute to the reduction of terrible outcomes associated with preeclampsia. So a very warm welcome to Sarosh, who's our own student, and today she's our guest of honor. I now hand over the proceedings to the chairperson of the committee, Professor Anjoo Agarwal, and talk about her committee and the speaker today.
Thank you so much, Dr. Tamkin, and a very good evening to all. And at the outset, I must congratulate the Stillbirth Society on this excellent initiative of making committees working on a single cause of stillbirth. That helps you to keep it focused. And hypertensive disorders, they continue to contribute a big chunk to stillbirths because they are commonly associated with other morbidities like obesity, pre-gestational diabetes, fetal growth restriction, abruption, and many more. In fact, I was looking at the literature, they are contributing to almost 16% of stillbirths. And another important fact is that out of these, 11% stillbirths are due to chronic hypertension and only about 5% due to preeclampsia. So our committee is really committed to spreading awareness so that we can optimize perinatal outcomes, identify important research questions, and implement the research. We need to create awareness not only at the tertiary level, but at the grassroots level. We really need to reach out so that we can ensure at least regular antenatal blood pressure measurement. which is still lacking in many of our facilities, so that women who have had some checkups, they still end up directly in eclampsia. So we really need to work on that. We already have a very nice referral group for PPH, and we hope to expand it to include preeclampsia and guide medical officers in their problems so that they can detect it timely and refer the patient timely. So in this quest for improving education in preeclampsia, we are very happy to welcome Dr. Revathi, who is a guest speaker today. She has done a fellowship in fetal-maternal medicine, and currently she is chief consultant and managing director at the Mirror Health at Bangalore. And she's also secretary for the Society for Fetal-Maternal Medicine of India. She's co-chair of preeclampsia education of the nation India, that is PENI.
Thank you so much, Dr. Anjoo Agarwal. The topic for today's presentation is optimizing maternal and perinatal outcomes in preeclampsia with insight into prevention of preeclampsia for stillbirth. Very, very important. I want to stress the fact that preeclampsia has been the underlying cause for perinatal deaths, and it's definitely time for action. And we know that the perinatal deaths could be something like 1,000 births attributable to eclampsia and preeclampsia. We know that 1 in 10 and 1 in 4 perinatal deaths warrants which could be attributable to eclampsia as well as preeclampsia, definitely requires greater efforts from both the maternal as well as the newborn community as a whole. And this is something that I would want to reflect. This is an article that I found with respect to what is the kind of contribution from different states. I mean, I would say that the brunt of the disease is definitely high in the northern states of Bihar, Assam, as well as Uttar Pradesh. So it is contributing something like between, say, 11 to 15 stillbirth rate. I mean, the stillbirths per 1,000 total births, which is like a very, very scary proposition. And there have been several articles looking at the causes for stillbirths, and it's just only not medical. There could be other factors. There could be behavioral factors. There could be social factors. There could be demographic factors, which could contribute. And of course, after anemia and sepsis, hypertensive disorders with preeclampsia definitely contributes to stillbirths to a large extent. Now, this is a very interesting article that I actually found from Chandigarh, and this was in 2017. And there they have actually figured out that the stillbirth rate in Chandigarh was about, this was actually published in 2017, and it said that about 16 for every 1,000 births was the stillbirth rate, and the antepartum causes were more common. It was about 68% than the intrapartum causes, which is about 32%. And among the maternal conditions in this particular study, hypertension contributed to something like 18.2%, and cholecystitis about 13.8%. And amongst fetal conditions, it was growth restriction and congenital anomalies. So more so, we should be committed as a society to prevent this. We should understand the root cause to prevent all the problems and optimize outcomes. So their conclusions were definitely the major causes and risk factors amenable to interventions were infections, hypertension, congenital malformations, fetal growth restriction. And that's why we are actually discussing it in such a big scale today. Now, we have to confront the facts. We know that eclampsia and preeclampsia accounts globally for about 1 in 7 maternal deaths as the underlying cause. Preeclampsia, eclampsia is similar in its contribution to perinatal mortality as major immediate causes of intrapartum complications, congenital anomalies, and sepsis. And what needs to be done, we need to systematically understand early and identify as early as possible of causes that could contribute to preeclampsia. And this, like how Dr. Anjoo said, yes, more number of antenatal contacts, particularly over the last 2 months of pregnancy, which cannot be achieved with the current 4-visit schedule as suggested by the government, and timely delivery before the woman reaches the life-threatening state. In fact, I would go back to the preconceptional period, just like the extended inverted pyramid, and try to modify the risk. But if it is not possible, just monitor the woman more frequently. effective management of those cases that progress to a life-threatening state that can probably cannot prevent preeclampsia completely, but at least managing at the right place, at the tertiary center with the right armamentarium of doctors, as well as the equipment, the NICU and things like that, blood can make a huge difference in preventing or morbidity and mortality, which is actually attributable to the disease. Now, with this background, I definitely want to discuss the study that we recently published, and the title of the study was the real life patient biomarker use in the management of hypertensive pregnancies in third trimester in a low resource setting, which was termed the robust study. What we meant the low resource setting was we're talking about an outpatient clinic, which is not directly attached to a tertiary setting. It's not a hospital. It does not have an ICU. It does not have an NICU. It is an independent clinic. So how did we manage our hypertensive pregnant women? How did we stratify the risk, and how did we optimize the perinatal outcomes? This could be extrapolated in a city, in a setting like a rural setup, in a village, anywhere. I mean, because you have several clinics operating which are monitoring hypertensive women, and definitely we should be looking at resourceful methods by which we do not cause unnecessary expenditure, but still not compromise on the outcomes. That is what we did. And this was actually published about a year and a half ago. And to just give you an introduction, we were looking at the angiogenic and the anti-angiogenic biomarkers. Now, if you're looking at the angiogenic biomarkers, the good one is the PLGF, or the placental-derived growth factor, which actually contributes to angiogenesis and probably protects you against endothelial dysfunction. And the bad one is the soluble FLT, which is the soluble form of tyrosine kinase receptor 1, which is probably going to antagonize the effect of the angiogenic biomarker, that is nothing but the PLGF. These biomarkers are reflected in the circulation, so you can measure these markers. So it's a very objective method of identifying a problem in case there is a loss of balance and you have more of anti-angiogenesis to the angiogenesis, which is actually reflected here. So if you're having a good amount of PLGF, which can neutralize the SBSI1, this is a normal pregnancy. But when you have more of the soluble FLT as against the PLGF, this is where preeclampsia this much before the clinical onset of disease. So you're not really capturing all the women and doing unnecessary surveillance, at the same time carrying, transporting the right women to tertiary care so that you can optimize outcomes. This was a very new thought, at least in India, though I've been working with the biomarkers since 2012. It was very difficult for me to actually convince that such a thing actually exists, and we can probably use this in real time to monitor pregnant women. So what did we actually, hypothesize? We were trying to use the serial surveillance. We were trying to use the biomarkers for serial surveillance. And when this biomarker turned positive, or a woman turned screen positive, which I'm going to probably tell you, and tell that this probably would develop adverse outcomes, we intensified the surveillance, did close maternal and fetal monitoring, and tried to reduce maternal and perinatal adverse outcomes. Now, what was the aim of the study? It was to evaluate the real life clinical utility. Basically, it was all looked at by the clinicians. This was a biomarker. This was at the molecular level, but the clinicians use these biomarkers, the angiogenic biomarkers, which was the SBSI1 PLGF ratio in an outpatient low resource setting, which did not have an ICU or an NICU. And what was the hypothesis? Amongst women at high risk of developing preeclampsia, the SBSI1 PLGF measured in the clinic should have probably a high negative predictive value of serious disease, which I'm going to elaborate very shortly. And knowledge of the SBSI1 PLGF will lead to increased surveillance in patients at high risk. So I'm going to tell you how we stratified the patients. And suppose somebody turns screen positive, we increased the level of surveillance. We delayed delivery in patients at low risk, and it was a very useful adjunct to clinical care. So we were not unnecessarily monitoring those women who are not going to get sick. At the same time, we channelized all our resources to those women who would probably get sick. Now, it was a pragmatic prospective cohort study. It was approved by the Institutional Review Board at Milan, Bengaluru, as well as the University of Chicago. We obtained a returned informed consent. Very, very difficult. We had to sit and counsel. We had women who were literate, not literate, all kinds of educational status from different economical backgrounds. And we had to tell them exactly what we were trying to do. And we included only singleton pregnancies because you could have different kinds of biomarkers, because the twins, the amount of angiogenesis could differ from what happens in a single pregnancy. So we need a different nomogram altogether. So we used only singleton pregnancies with all kinds of hypertension, like chronic, gestational, whatever. And we started recruiting them in the third trimester, that is at 28 weeks. And we found that so many women did not really come to, met us only in the mid-second trimester or in the third trimester. So they also benefited with this kind of a surveillance protocol. The time period was July 29, 2016 to July 9th of 2019. All patients enrolled in the outpatient clinics at Milan hospitals, as well as its centers. My center is also an affiliate center to Milan, were all recruited into the study. We made sure we counseled them. We told them that we were not doing any unnecessary blood tests. We would probably monitor them along with their regular PET profiles. We did not incentivize any of the patients. We made sure that we used up the blood samples that we collected during the PET profiles for analyzing. Fetal surveillance with the SBSI PLGF was measured on a Roche ELISIS platform. The main outcome measures. So what we did, we recruited all the singleton pregnancies. We looked at them beyond 28 weeks. We could recruit them only up to 37 weeks because we did not have values beyond 37 weeks to, probably stratify the risks in these patients. And we were looking at the maternal complication rates, the development of preeclampsia with severe features, as well as the most important thing, latency to delivery after biomarker result. So subjects were identified through prenatal visits. Samples were collected from consented patients only. We had so many patients who did not consent to be with us till delivery. And we were very, very sure because these, the biomarker kits were given to us by Roche. So we did not have many kits. So we had to make sure that we had to recruit only those patients who were probably going to be with us or promptly tell us what happened to their outcomes because we were investing quite a lot on them. They did not pay for the biomarker test. So it was a big deal. So we had to get only those kinds of patients. The SBIT and the PLGF was measured within 30 minutes, but believe me, the trend has definitely changed from what we did in this study. This study has given us the confidence to tell our patients that yes, now it is, worthwhile to invest on the biomarker and these patients have formed their own support groups and they're probably coming for, asking for it, when they are hypertensive. So the SBIT1 PLGF ratio was calculated and managed, and I'll be telling you how we did it. And all patients followed usual clinical care with addition of information from the biomarkers. We did not deviate from our clinical protocols. We were looking at them just like what we did, but we understood what the biomarkers, indicated, and it was real time and it was prospective. Then standardized chart abstraction was performed and the clinical data and outcomes were entered on, on data collection forms. And this was by trained staff. Yes. And the clinical data included information as maternal demographics, the medical as well as the obstetric history. And we also made a note on the different outcomes, both maternal as well as perinatal outcomes. Now, what are the methods? The diagnosis of gestational hypertension, preeclampsia with or without severe features, and chronic hypertension were made following the ECOG guidelines. All diagnosis was confirmed by me, who was the first author. The composite maternal adverse outcome was defined as any of the following. That was antepartum hemorrhage, placental abruption, HELLP, eclampsia, as well as anybody who was probably less than 33, SBIT1 PLGF less than 34 was screen negative. The same thing held good for anybody who was less than 34 weeks. So anybody who was less than 33 was considered to be screen negative. Then we looked at 33 and 85 to be borderline positive in those who had a value less than 34 weeks. And somebody who had more than 85 was considered to be screen positive. But if you're looking at the SBIT1 PLGF ratio, more than 34 weeks, 33 continued to be the cutoff for screen negative individuals or hypertensive pregnant women. The ones who were between 33 and 110 were considered to be borderline positive, and beyond 110 was considered to be screen positive. And please remember that these values, even in screen positive patients, we were able to get these values when the women were clinically asymptomatic. They did not have any signs or symptoms of preeclampsia, and that was the edge. We were able to identify the right kind of people. At the same time, did not lock those patients who were screen negative, because they were old or they were ARD pregnancies or they had other medical risk factors in the hospital, trying to tell them that we don't know when you would probably develop preeclampsia. And we had a very objective method of identifying this test, and it was just not premonition or a gut feeling that yes, you would probably develop preeclampsia. And this is something that probably helped us to counsel our women. And in fact, we were able to do it even in women who are not very, very literate. Okay, so after stratifying these women who were recruited beyond 28 weeks, and we tried to monitor these women once in every 2 weeks. I'm trying to tell you how frequently we monitor these women, and we use the biomarkers along their conventional testing. So if somebody was recruited at 28 weeks, we would identify what the SBSI test actually result was. And in case she had a value of less than 33, we also did all the conventional tests for maternal fetal well-being. We called her only once in every 2 weeks up to 35 weeks. But suppose somebody turned borderline positive, that is, if it was something like, between 33 and 85 in 34 weeks, or between 33 and 110, more than 34 weeks, we did a similar testing, which included the SBSI ratio after a week till screen positivity. We had to decide this because we did not have, many kids. We had to optimize whatever we had and still do good to the patient. But if somebody turned screen positive, whatever be the gestation, less than 34 weeks, beyond 34 weeks, we would probably tell them to get admitted and say, probably 24 hours, we'll monitor what's happening to the disease. We don't know what from the maternal side or the fetal side, or whether it's maternal fetal. We would probably do that, but some of them did not agree. But we said we will do close monitoring. We won't call you after 2 weeks. We're going to call you bi-weekly. And we did all the tests for surveillance. And whatever test had a problem, we repeated it more frequently. So clinical surveillance played a very important role. We did not base any of our decisions only on the biomarker. We used the biomarker only for stratifying patients. And all the delivery decisions were actually given to us by, a clinical, we did the delivery decisions only with respect to it was purely clinical. But if somebody remained screen negative beyond 37 weeks, I can tell you several examples where we continued them, beyond 37 weeks. We told them, we explained to them that you need to come more frequently. We did their tests like twice weekly and probably improved their Bishop score and delivered them vaginally. I'm not saying, it's the whole idea was only to deliver them vaginally, but they were safe and we were able to give them in the ideal candidates a properly timed vaginal delivery at 39 weeks with a better Bishop score. So basically it was at looking at the woman from the root cause perspective as a whole and not just looking at, consequences of preeclampsia and just looking at management of the disease after it is completely established. Now, if you're looking at the results, if you're looking at the average SBSI ratio, it was about 9.4 in the low risk. It was about 54.4 in the intermediate risk category. And in the high risk, it was 164.6. And it was a significant peak. If you're looking at what was the BP patterns, the blood pressure patterns in the low risk category, the values were something like about 140 by 90. The total numbers were 50. In fact, we actually did two preliminary analysis before we actually published the study. And in fact, we wanted to recruit maybe about 100 or 150, but because the trends were happening, we wanted to restrict ourselves to about 50, but we had about 135 encounters with the SBSI, which was a lot of information for us to understand what was happening to these patients, because every patient contributed to 7 encounters with the biomarkers. If you're looking at the intermediate risk category, we had about 12 women, and the systolic diastolic was about 150/90 on an average. And if you're looking at the high risk, it's 160/100. That is anybody who had an SBSI of 85, and that was also a significant peak. And if you're looking at the NICU stay, obviously some of these patients were delivered early, and the NICU number of days were definitely higher in these women. But what I want to emphasize is these babies did not die. They were more, they were growth restricted. They lived in the NICU, and we've been looking at their outcomes. Even till date, we've had some of these women telling us about their babies, even at 3 years, 4 years, these babies are doing well. So we did not actually deliver hypoxic babies. We delivered babies who were probably going to be salvaged much before they had a hypoxic inside, but they did stay in ICU for somewhat longer time. And for this kind of a group, I think this is very, very significant. Maybe these are the babies who could have probably ended up in being stillbirth or something like that. So the diagnosis of preeclampsia or with severe features was definitely more in the women who had, it was 10 as against 2 with the high and the low risk rate. Basically, there are 3 circles. And this circle tells you about what happened to these women who were negative, who were screen negative, who were borderline positive, and who were screen positive. So out of all the 50 patients, there were about 103 who had an SBSI PLGF value of less than 33. And these women, what was very heartening is these women did not develop preeclampsia with severe features 100% of the times. And that was so valuable. I didn't have to admit her. I had enough time to talk to her. I could send her home because, see, just admitting the patient is not just only about her ward charges. It's about the entire family, who have to probably contribute in her care, and they would lose a lot of money economically. And that was very reassuring. And this closely matched with the prognosis study where you look, it probably said about 99% and above did not have preeclampsia with severe features when they were screen negative on the biomarker. In fact, we also looked at what happened to women between 33 and 38, because this prognosis study came in slightly late, maybe at 2016 when we had already started recruiting patients into our study. So we didn't really change the protocol. And what we really understood is there was not much of a difference when the cutoffs of 33 and 38 was changed. If you made somebody from 33 to 38, there was not significant difference in what happened to them clinically. So we could, for all practical purposes, use the single number 30 as the cutoff point and say anybody who's less than 38 is not going to develop preeclampsia with severe features 100% or close to 100% of the times in the next 1 week, which is a very important information for the clinician. So what happened to women who were above 85? The positive predictive value was also very good. 60% of these women developed preeclampsia with severe features. So this is what I'm trying to say, that use this cutoff of 38 and say they are negative, and probably use the other cutoffs to find out whom you're going to do the surveillance. So if I'm going to conclude this study, the SBSI PLGF ratio had a high negative predictive value for diagnosis of preeclampsia with severe features. None of the patients with a low risk ratio developed severe preeclampsia within a week of the negative ratio. Higher rate of preeclampsia with severe features and composite maternal adverse outcomes was seen in women with the elevated ratio, and pregnancy management based on these factors led to intensified surveillance in those at highest risk for adverse outcomes. We were not looking at all women. We were only looking at women who would probably get sick, and allowed for routine surveillance in those. We did not get scared about managing hypertensive women in our clinics at low risk for adverse outcomes. We did not detect any significant maternal or neonatal morbidity in the group with decreased surveillance. Serial measurements performed in our study demonstrated that risk initially continued to remain low risk on subsequent measurements. So that's what I was trying to say. And those with a high risk ratio had more preterm deliveries and definitely high frequency of NICUs, but did not have IUFD. In fact, the kind of setup that we had did not have many IUFDs, but definitely getting to that level was more, we were more confident with the biomarkers, and that we should probably emphasize. Limitations, yes, it was a small center study, single center study. We were looking at a center which was already monitoring women, with more surveillance, and the study did not compare outcomes of patients managed with or without biomarkers. But yes, we want to do a bigger study and compare, with or without biomarkers, and do it like a multi-center trial in the long term. And long-term outcomes on units, I have been doing that. I've been trying to collect what's happening, and it's very, very reassuring that most of these neonates did well, except for one, which probably died at the end of 1 month. So this is how that look. It is difficult to do primary prevention in preeclampsia. You cannot tell a woman that she's obese and she has all the risk factors and she should not get pregnant. What we can do is modify the risk. Secondary prevention, we're talking about aspirin and calcium. Yes, it has definitely a great role in our country. Tertiary prevention still, is to be emphasized in our country. We need to treat them with because the problem has already occurred. At least to prevent progression, we need to know how to use the antihypertensives and use Maxalt whenever it is required. Now, you could probably read this in the ISHP 2021 guidelines. It clearly tells us all women have to be counseled. They have to do a little bit of exercise to make sure they are metabolically healthy. Women who have a low calcium intake, less than 900 grams of calcium, I would say in our country, we would definitely have to give them calcium, at least 1 to 1.5 grams. There's no role of low molecular weight heparin just to prevent preeclampsia, vitamin C or E, but definitely use heparin whenever it is indicated. You can't, probably deny heparin in a woman who's APLA positive and she would probably develop preeclampsia. So I would still emphasize the role. It's just not about the history. If it is possible, at least try to stratify them based on their history. If it is possible, try to measure the mean arterial blood pressure. I know it is cumbersome. You have the FMF calculator, or if it is possible in the first trimester, use the PLGF test. Tell the women who are at risk to use this and then start ecosprin at the right time. Ideally less than 16 weeks, 11 to 14 weeks ideal, but the ICOC still says use it less than 16 weeks. Even if a woman comes to you in the third trimester, 26, 28 weeks, give them aspirin. And the recent ISSHP guidelines clearly says don't use, aspirin less than 100, because it's definitely not going to help, because 40% of these women are going to have platelet insensitivity to aspirin. So use a dose beyond 100 and then do vigorous monitoring and surveillance. And I think I will stop here.
Thank you so much, Dr. Revathi, for an excellent presentation. And I request Dr. Seema to take over the proceedings from here.
Thank you, ma'am. And now taking the program forward. And next we have panel discussion on stillbirth from hypertensive disorders and renal diseases. And to moderate this panel, we have none other than Dr. Girija Wagh. Madam is Professor, Department of Obstetrics and Gynecology, Bharati Vidyapeeth Medical College Hospital, Pune. And she's also Senior Consultant Cloud9 in Apollo Hospital, Pune. And she's Vice President of Foxy Base Zone and has held many prestigious positions in Foxy. And co-moderating the panel along with her is we have Dr. Latika Chawla. She is Associate Professor, Department of Obstetrics and Gynecology, AIIMS Rishikesh, and she's doing a lot of good work in fetal medicine. And we have a set of very learned panelists for enlightening us on this subject. Dr. Charmila, she is Vice President-elect Foxy and past chairperson of Clinical Research Committee Foxy. And we have heard her in many webinars and her panels are very interesting. Then we have Dr. Vinita Singh. She is Consultant Obstetrics Medicine, Royal Free Hospital, London. Next, we have Dr. Priyanku Roy, and I would say he's a young achiever, and he's a chairperson, elect Public Awareness Committee, Foxy, and is Vice President, World Association for Trainee Obs and Gynecologists, FIGO. Then we have Dr. Pratibha Singh. Madam is Professor and Head Department of Obstetrics and Gynecology, AIIMS, Jodhpur. Then we have Dr. Richa Vatsa. She is Assistant Professor, Department of Obstetrics and Gynecology, AIIMS, New Delhi. Next, we have Dr. Bhumika Bansal. She is a young and energetic gynecologist from Lucknow, and she is consultant obstetrics and gynecology, fetal medicine at Apollo Hospital, Lucknow. And then we have Dr. Namrata, my dear colleague. She is associate professor, Department of Obstetrics and Gynecology, King George Medical University, Lucknow, and she has recently been awarded MRCOG. So over to Dr. Girija and Dr. Latika to start the panel.
So at the outset, many thanks to Dr. Anjoo for inviting us, and especially I must, before I start on this panel discussion, I must make a disclaimer that these wonderful slides and the entire material has been put together by Dr. Latika Chawla, who is the fetal medicine specialist.
Thank you,
and she has connected to us also from a very distant place. And in the beginning of this panel, I'll request Latika to conduct this panel because we are a little doubtful about her internet connectivity. and we should not miss on the contributions coming from her. So Latika, you please take, and before I give the screen to Latika, I would love to welcome all the panelists who are, some of them, all of them actually are my dear friends. And I'm sure that in the next 45 minutes, we are going to try to cover all those aspects about HDPs and renal disorders in context of stillbirths. Yes, Latika.
Thank you so much, ma'am. At the outset, I want to thank the organizers, especially Professor Khan, Professor Agarwal, and Professor Mehrotra for giving me this opportunity. I've been an MBBS student of theirs, and I'm actually extremely honored to be, at this platform today. Greetings to all the panelists. And we've kept the questions at a very basic level, so the discussions we want should be, how we deal with the patients on a day-to-day basis. Because at the end of the day, what do we want in a patient of hypertension? We want a good outcome for the mother, and we want to hand over the mother a healthy and alive baby. So the discussion that we hope is just something very simple, which we are doing on a day-to-day level. So sitting, in a tertiary, working in a tertiary care center, we've realized that the majority of cases that we get as reference are women who have high blood pressure in pregnancy. And even to this time and date, it's very sad that we are seeing almost all possible complications of hypertension, which have been enlisted in our books, way back in the, even those complications we are seeing today. And it's very unfortunate. The stillbirths is one of the top charters. So let's move on to the questions in the panel. So moving on to the stats, what is the current MMR in India, and hypertension contributes to what percentage of the maternal mortality? Dr. Bhumika?
Okay, so I guess the current MMR in India as per 2019 census is somewhere around 103 per 1 lakh live births.
Absolutely.
And yes, and preeclampsia or hypertensive disorders of pregnancy roughly contribute to around 7 to 9% of those maternal mortalities.
Right. So that's exactly what our slide was showing. It's 103 per 100,000 live births, and 7% of all direct causes of maternal mortality is because of high blood pressure in pregnancy. Next slide, ma'am, please. So what is the stillbirth rate in India? Dr. Richa, would you like to answer this question?
Stillbirth rate is in India is around 14 per 1,000 live births.
Exactly. So it's 13.9. And as you can see at the top of the slide, it's very unfortunate that India has the highest number of stillbirths in the world. So this is the latest data that we have from 2019. So we need to know what are the main causes of stillbirths. Can somebody list those?
Stillbirths, actually 40% occur during labor, and the Royal College says almost like 1/3 is unexplained, and most will have SGA. So you will have your reasons as intrapartum cause or antepartum causes. And if it's going to be antepartum causes, it may be a infectious cause, it can be a birth defects, or it can be a disease where you have got a placental dysfunction. So that is
what are more? Are the antepartum causes more or the intrapartum causes more?
Antepartum causes.
Antepartum is more, intrapartum is 40%.
Absolutely. And again, you have this statement given by the ACOG, endorsed by the Society of Maternal Fetal Medicine, that hypertension and pregestation diabetes are two of the commonest comorbid pregnancy conditions that are associated with stillbirth. And that's why we are here today discussing about hypertension and how to prevent stillbirths from hypertension. So there was this article which was published. Dr. Rajan has already discussed this article, and we've already got this number before. So the stillbirths intrapartum are almost around, let's say, 30%, and 68% are antepartum. And then we can further classify the causes as maternal and fetal causes. So here, hypertension again tops the chart. It's 80.2% of all maternal causes of stillbirth are as a result of hypertension in pregnancy. Now, it's very important to note that majority of stillbirths are preventable. So you need to understand that all women require good antenatal care during pregnancy. It's important to, in our country, in our setup, where women don't even come to the hospitals for their antenatal checkups, We need to give them high quality care during pregnancy and childbirth. We need to identify the complications, pick up the complications, and timely intervention in case of complications. And in case the pregnancy reaches term and she's going into labor, it's important to give good intrapartum monitoring. So can somebody classify, one of the respected panelists, classify hypertensive disorders in pregnancy?
So Namrata Kumar.
Yes, hypertensive disorders in pregnancy can be classified according to the Society for Hypertension in Pregnancy into gestational hypertension, by which we means that it is blood pressure more than 140 and 90 millimeters of mercury after 20 weeks in absence of any features of preeclampsia. Or the second one is preeclampsia, which could be with proteinuria or features of severe disease, which might include acute kidney injury, liver involvement,
I think Latika has
complications, and then superimposed preeclampsia on chronic hypertension.
Okay. So very rightly said, we divided into pregnancy, hypertension less than 20 weeks and more than 20 weeks, and it's already there on the screen, ma'am. It's chronic hypertension, widespread hypertension, and masked hypertension that's in less than 20 weeks. And then, ma'am, can you move on to the other slide, please? We have gestational hypertension, blood pressure more than 140/90 after 20 weeks in the absence of proteinuria. And next slide, ma'am. Preeclampsia, the definition has changed from what we read back then in our MBBS and post-graduation days. So BP of 140/90, more than 20 weeks of gestation with one of the complications that includes either proteinuria or organ dysfunction or uteroplacental dysfunction. And chronic hypertension with superimposed PE, again, the definition is slightly changed. So women who have chronic hypertension, there's development of new proteinuria or organ dysfunction or uteroplacental insufficiency is there. Now, it's important to know.
Yeah. We should make an addition to this factor that if there's chronic hypertension in a woman, which you diagnose, because many times women are coming to us in the first half of pregnancy, it's important that we investigate them for the causes of this hypertension. It may not be always an essential hypertension. It can be a nephritis. It can be a nephropathy. And that is also very important to look at because that can contribute to stillbirths and adverse perinatal outcomes. So that is additional thing that we require to look into.
And Girija ma'am, I also have one thing to add, like this ISSHP, it says it does not classify preeclampsia into severe or without severe features, but ACOG classifies in preeclampsia into severe with severe feature or without severe feature. This is a major difference between these two classifications.
Absolutely.
Right, Dr. Richa. And
even if they don't mention it in the guidelines we go through, they are mentioning non-severe variety.
Yeah,
so it's almost like they accept the severe and non-severe, not mild, but severe.
Yes,
yeah, so I think that's I was part of the guidelines. The thing that they wanted to get away is that calling something mild and calling something severe, because there's nothing like mild preeclampsia. Like if you have hypertension, proteinuria, or even without proteinuria, you're at risk for adverse outcomes. So we were trying to get away from using the term mild and severe, but there is definitely all the management depends on whether you have. So we are trying to say preeclampsia with severe features, which is a very different disease entity versus preeclampsia without severe features. So you're right. I don't know who mentioned that, but if you actually read the text, pretty much all the management depends on whether you have severe features or not and how many gestational weeks you are, 34 or less. So I think, I think very good.
Preeclampsia is basically a disease. Even if the BP is 140/90, it can be severe enough to lead to complications. So that's why they've gotten rid of that.
Yeah, so they're not calling it mild and severe preeclampsia, but you put the word preeclampsia first. So you start with saying the woman has preeclampsia, and then you say whether she has severe features or she doesn't have severe features. And based on whether she has severe features or not, you decide what to do with her pregnancy.
The management changes. Absolutely, ma'am. Thank you.
Correct.
I agree with you. The problem with the preeclampsia is that the unpredictability of the course. The one woman with so-called mild preeclampsia could be within 24 hours progress to severe preeclampsia, and putting the word mild gives us a very, very false reassurance. So preeclampsia is preeclampsia, and it needs to be monitored as preeclampsia, and all of us to be aware of the consequences that can come with the preeclampsia, both maternal and fetal.
Correct.
Right. So we move on to our first case scenario for the evening today. So we have a second gravida with a previous abortion. She's at 32 weeks period of gestation. and she has come to your antenatal clinic. Her blood pressure was 150 by 100 millimeters of mercury, and you checked it again after 4 hours. It was still in the same range. Urine albumin by dipstick was 2+. Obstetric examination, 30 to 32 weeks period of gestation. And she gives the history of home BP records in the range of, again, 140 to 150 with a diastolic of 90 millimeters of mercury. So I would request one of the esteemed panelists to kindly take this question. Can you just broadly define as to how you would approach?
Yeah. Okay, I think Bhumika wants to speak. Dr. Bhumika Singh, yes.
In preeclampsia, we rely more on the home BP measurements compared to what the patient is giving, what the patient is measuring in the office. So considering that her home BP records are in the range of 140 by 90 to 150 by 90, and the dipstick protein is 2+, we take her as a case of hypertension, blood pressure wise, as a mild preeclampsia, and then we do her maternal and fetal evaluation both. So for the maternal evaluation, we would do all her biochemistries, in which we take a hematocrit, platelet count, a CBC in general. CBC we'll send, a liver enzymes, liver function test to get her liver enzyme status, a kidney function test, LDH we'll do, and we'd also like to check for her fundus examination, a 24-hour urinary protein. If the patient, the 24-hour urinary protein would be a better estimation of the proteinuria that this patient is shedding. So we do the maternal investigations, and then for the fetal surveillance, we check for the Dopplers, we do an antenatal testing, we see if the baby's growth is no growth restriction, and since the patient is 32 weeks and the disease may progress rapidly, that we may need to do a delivery, we may want patient with antenatal corticosteroids also. And then we need to put this patient on a strict bi-weekly or a weekly surveillance to see for the course of disease, in which we tell this patient to do her home BP records. We would ideally want to check her again after 24 hours with a home BP record of 24 hours. And if the BP is consistently in the range of 150 by 90, I suggest we might start her on antihypertensives to begin with a dose of labetalol, 100 mg twice daily, to put the target blood pressures to roughly around 130 by 80 to 130 by 90, and see for her home BP records, call her weekly with all her biochemical parameters and do an antenatal testing. If the blood pressures, yes.
Yeah, just a moment. I would like anybody on the panel to just to sort of, identify that there are certain issues. I would suggest, Bhumika, that we shouldn't call this as mild preeclampsia, because just now we realized, Dr. Sarosh also mentioned the same thing, that there is no entity nowadays as mild preeclampsia. So we have to call her as preeclampsia. We have yet to investigate her. So we will then only come to know whether she has severe features or not. So from that time onwards, and I think antihypertensive medicines should be started off right away. Anybody on the panel would like to comment on this? Because the CHIP study and the CHAP study currently are saying that immediately start on antihypertensives. So anybody would be.
So basically the important thing is that we have to understand how this disease is progressing. The woman is only 32 weeks. And our first reflex is to take her to 34 weeks, and if she's stable, then to 36 weeks. So by that we means we have to see if the disease is stable or if it is progressing, and to see if the disease is stable for mother and the baby. For mother, if her blood pressure remains less than 160 over 110, and if her biomarkers are not deteriorating, if her PCR is, PCR is just for identifying if her kidney functions or liver functions are not showing features of HELP or the kidney failure. And if the CTG and the Doppler doesn't indicate any acute compromise, then we will monitor her. But if anything changes, then the aim would be to deliver her. So basically it's monitoring till we can monitor.
Charmila, you want to say something?
Girija, very simplified. A person comes with 150 by 100, already had a blood pressure of 140 by 90 before that. Review her to find out whether she's a chronic hypertensive or she's a gestational hypertensive. If she's a chronic hypertensive, she's going to be a superimposed now. Gestational hypertensive, she's progressed now. So she's preeclamptic. You're not going to put her as anything like mild or severe. You're going to investigate her, ask her for symptoms, do the fetal surveillance, fetal testing basically, then label her as severe or the lesser variety. If she's going to be severe variety, You're already giving her antihypertensives because I saw her blood pressure was 140/90 even before she became a preeclamptic. So antihypertensives should have been started at 140/90, kept as a target of 130/85 to make sure that she's controlled. And now she has become preeclamptic. That means she is not controlled. So change your antihypertensives or add your antihypertensives. Make sure she is controlled and monitor both the mother and the baby appropriately depending on the results you got from the maternal testing and fetal testing. That should
right. Thank you. So one very simple question I want to ask the panelists: are you going to admit this patient, or is she going to be for outpatient?
We will admit her.
So you will admit all patients with BP of 150/100?
No, because of a proteinuria.
Any
I
other?
would admit her.
Just
I would say yes, admit her, but not because of her proteinuria. Proteinuria has been repeatedly shown to have no real prognosis.
But
so I would not admit her for yes, but I would 100% agree with Dr. Singh to admit to monitor exactly what she says. So you have to start with the diagnosis and go forward to investigate whether she has severe disease or not. We admit all our patients with primary diagnosis of preeclampsia because you haven't really established whether she has severe disease in the next like 24, 48 hours. So you admit them for betamethasone and you admit them for blood pressure monitoring. She could be severe pre-E just based on her severe hypertension. So you haven't really established that. And I don't know who was talking about home blood pressure monitoring. Actually, a bump trial just came out saying home blood pressure monitoring actually doesn't really do much. So of course, home blood pressure monitoring is really important. If after 2 days you establish her labs are normal, she has no symptoms, her fetal growth is appropriate, baby testing is fine, her blood pressures are non-severe, you start on antihypertensive, you send her home, absolutely you do home blood pressure monitoring. But I would not make the diagnosis on the spot and then send her home for home blood pressure monitoring because 2 hours later she could have a seizure. So I would agree. I don't know who asked the question, but yes, admission for all patients who are preterm to establish whether they have severe features or not.
Right,
so,
ma'am.
I mean, if she was 37 weeks, you could have just delivered her.
Absolutely. So, go ahead with the admission of the patient.
And also, we can give her steroid by the time we admit her and look at all the investigations which we have. So within 24 hours, we can have all the reports of the investigation. We can have a look at her blood pressure, as well as all the reports will be available with us. So that will make us better equipped to manage her further. So definitely,
I beg to disagree. As far as steroids are concerned, you have to be very careful with in which patients you choose to give the steroids, because right now, without workup, there's not really any indication for termination of pregnancy in this patient. So even if she's 32 weeks, you still have to wait and watch and then consider giving steroids.
Absolutely not, Latika. Absolutely not. Every guideline says patients, yes, any patient between 32 and 34 weeks with a new hypertension and proteinuria, you have to give them steroids because she is at a very high risk of delivery in the next 1 to 2 weeks. Every guideline, if you pick, every guideline, I don't know what ISHIP is saying latest, but every guideline says anybody who's viable, unless you've given her steroids before for whatever reason, you have to give them betamethasone at the time of diagnosis.
Absolutely.
Absolutely.
I will differ in that.
I'm not very sure about that.
I'm really sorry.
Sarosh, I would also like to go a little ahead of this, that even in this patient, even if whatever that delivery imminent, not imminent, we can consider giving her magnesium sulfate for neuroprotection. Likewise, because we do not know. One of the most important things, since we are speaking in context of stillbirth, is we have to also consider she's at risk of developing abruption. She's at risk of, having a seizure, and both of them can be detrimental to the baby also. So therefore, I would always give magnesium sulfate as well as steroid. In our country, we give dexamethasone. So that's what we would be giving. And we admit them as per the RCOG protocol of 24 hours magnesium sulfate for neuroprotection. If she gets temporized, gets classified as somewhere we can give her expectant management, so be it. Doesn't matter. But you have given her that, benefit of advantage.
So I would do it a little differently. I would admit her for 24 to 48 hours to understand the progression of disease. And if that indicates that this woman is likely to deliver soon, then we would give her steroids. Otherwise, we would hold off the steroids for a little bit.
That's right.
But if there's any chance that indicates that we might deliver her, then we would give the steroids. And I agree with the magnesium sulfate that if you're considering delivery, we would give her magnesium sulfate only if you're considering.
So I think all panelists and everyone
maybe okay. So maybe
I have a question to ask to any of the panelists. I think I'll throw it to Charmila. Sarosh will always say this, but I want to ask Charmila, should we do PLGF in this patient?
Ma'am, I don't have a facility of doing, I don't do.
So you don't do. Anybody else?
So ma'am, I have been doing a project on PLGF and SFLT, and I would be like, I think that this has a great role in such kind of a patient.
And anybody, can you tell me your name, please?
Can I just
allowing me to see you?
Ma'am, I'm Namrata.
Yes, I'm Dr. Revathi, ma'am. Can I tell you?
Now let Namrata speak, because I know she's not spoken for some time. Let's
ma'am, I am Namrata. I'm working as associate in KGMU. So I've recently got a project sanctioned for this markers under the Council of Science and Technology UP. So where I'm actually doing these markers in these preterm women who are coming with preeclampsia, and we are not sure whether we have absolute indication for termination, and we are actually monitoring them. So these markers have actually emerged as a very, very important like guidance tool. We have realized that in situation where these markers are low, even if the biochemistry is little bit raised, we often find patients who have, SGPT like 56. It is actually raised from the cutoff, but the woman is not having a severe feature of the disease otherwise. So in such a situation, if SFLT and PLGF are low, they're able to actually prolong the pregnancy and under guidance.
Have you even tried to study with other parameters, like for example, LDH or renal
Yes,
function?
ma'am. Yes, ma'am. I've realized that none of the biochemical parameter, LDH, be it uric acid, be it SGPT, none of it matches to an extent to which SFLT and PLGF match. And the ratio is absolutely amazing.
Have the word from Dr. Sarosh Rana and Dr. Sarosh Rana, please. Yeah. And Dr. Anjoo,
can talk about
guide us. If we are going over the bounds in time, we'll want to stop the discussion at that time.
Not at all. Not at all. We are thoroughly enjoying it. You can go on and on.
Getting views.
So I would say that Namrata is absolutely right. So when you look at positive predictive value of any of these things that you're measuring, blood pressures, your LFTs, your platelet count, your, even LDH, we kind of stopped measuring LDH. It doesn't really provide any additional prognostic value. They are very poor prognosticators for adverse outcome. In fact, as poor as 20%. So what Revathi was showing in high-risk population where you're suspecting preeclampsia. So here a woman comes in, she's got hypertension, proteinuria. You're unclear what her course of event will be in the next 1 to 2 days, 2 weeks. The biomarkers are absolutely very good in classifying her whether she's at low risk. And I do agree with Dr. Wagh that currently obviously biomarkers are not widespreadly used, but I don't know who's the one who's doing the study. I mean, I think that's the study you guys can do in India because I can't do it in the United States. But absolutely, yeah. So I think absolutely classifying your patients on basis of biomarkers and then stratifying them. And then if they have a low biomarker profile, like we were suggesting less than 38, they are at almost no risk to have an adverse outcome related to preeclampsia. And Revathi didn't present the data, but there's lots of data that the biomarkers also correlate to timing of delivery. So your risk to delivery in the next 1 to 2 weeks is very low if you have a low biomarker profile. So I would agree with the panel that in that case, if you're measuring the biomarker and you objectively know that her risk is low, don't give her betamethasone. But right now you guys are not doing that and we are not doing that. So it's very confusing. But yeah, so the positive predictive value on the same side for the biomarkers is as high as in this patient, will probably be as high as 70%. So you take that 20% with your current tools that you are using to all the way up to 70%. So yeah, so if you guys are using the biomarkers, you can definitely use it to classify your patients and then manage them accordingly. So if you're high risk, you admit them, you give them steroids, you can, plan for delivery, whatnot. And if they're low risk, sure, you can just possibly send her home an antihypertensive and say, I'll see you back in a week or so.
Absolutely. Fetal surveillance in this patient a little more in detail.
You would have done probably a screening for a uterine artery Doppler before, because already she's around 30 to 33 weeks. Now you'll do a fetal ultrasound for biometry, the amniotic fluid, as well as probably for the Doppler also. Suppose you're having a growth restricted baby.
Probably you should do Dopplers in this patient, because now what you're interested in whether is the FGR is setting in or not.
Yeah, any fetal medicine specialist you send they do all three anyway. So once you have done that, depending on the Doppler changes, you will be managing the baby later on. Suppose
Charmila, what I think Latika is trying to bring about is a very important point, because the thing is, we have to remember that preeclampsia is a placental disease, and therefore Dopplers are going to help. Why am I saying this specifically is, we are in the urban settings very fortunate that when we send the patient, the sonologist will do the Doppler and send us back. Or we have fetal medicine specialists, but there are so many of our colleagues who are deprived of this. They will only have the biometry coming, and they have to specifically then mention that please do the Dopplers, you understand? Or sometimes they themselves are doing. So it's very important that we have to do the Dopplers, as Dr. Latika said, because that's only going to help us in identifying what should be the frequency of these Dopplers.
Suppose you've got a change in your Dopplers and it is not severe, then you would like call her twice in a week. Every third day you'll be doing. And we will also be doing a CTG to see how the baby is doing. And then suppose the Dopplers have changed and you've got probably a absent end diastolic flow, it will be more frequent monitoring. Like you would probably call her every day and do it, and that patient would have got admitted also. But suppose it's a reversal, your ductus venosus flow is also very important now, and you would be doing the Dopplers every day and sometimes even twice or thrice a day to find out how the blood flows are.
I think we have the slide a little later, but I didn't want to disturb the flow. We'll come back to it again. We were talking, and in the beginning, Dr. Bhumika Singh said that we will be giving antihypertensive medicines. First, she said 150, 100. Then she said, yes, the target would be 130, 80. Do we all on the panel agree to this? That you would be starting looking at antihypertensive medications only in severe disease, or will a blood pressure of 140, 90 and beyond will make you start antihypertensive medicines?
I would start at 140/90, definitely.
Okay. Anybody else on the panel?
Yes, ma'am. We'll start at 140/90.
Yes. I will feel like starting at 140/90.
Yeah, so now we have to look back at our guidelines, whatever the Foxy Justice's HDP said 150, 100, or whatever we had been talking about severe hypertension after 160, 100, that all has now decided to change to the fact that even if you have blood pressure of 140/90, because in both the CHIP study and the CHAP study, it has been proved that this is going to reduce the maternal morbidity significantly, not affect the fetal growth restriction, and therefore this will definitely help us in avoiding stillbirths. That is our focus today, because we will not have then the placental issues and other things in this mother. So what are your choices of antihypertensive medicines?
Dr. Wagh, there's a question in the channel. What would Dr. Rana say about when to start antihypertensive? Okay. So I would 100% agree with you. Yeah. In US, we are not really kind of following the CHIPS trial. So the CHIPS trial was essentially based on gestational hypertensive and preeclamptic, and they said, well, reduce the blood pressures to a diastolic of 85. CHAPS trial that just came out is really about chronic hypertensives. It's not about preeclamptics. And CHAPS trial is saying start early antihypertensive in the first, second trimester is going to prevent you from having hypertension in the third trimester. But I would agree. I think if you follow the ISHIP guidelines, and hopefully ACOG will change the guidelines. So if you ask me currently, what am I doing for my preeclamptics at term, like close to in the third trimester, if they do not have a history of chronic hypertension, we are actually waiting for severe hypertension. We are not following the CHIPS trial in the United States right now. CHAPS was chronic hypertensive. CHIPS was preeclamptic. So I think you guys are doing the right thing in following both CHIPS and CHAPS, while we are kind of trying to integrate. CHAPS is integrated. So if you have a chronic hypertensive in the clinic, you start antihypertensives. So I think you're saying the right thing. I start all patients on antihypertensive. I'm a big, reduction of blood pressure to reduce all maternal and fetal morbidity.
Yeah, because absolutely. We have to look at the mother in context. The focus Correct. Is gradually moving to the mother also, because all Correct. Of us.
And her risk of stroke is high. Her risk of acute kidney injury is high. And like you suggested, I think the risk of IUFT is high in women who have uncontrolled hypertension. So 100% for all of you guys, treat blood pressures, anything over 140/90. Absolutely.
I would like to add something here, Dr. Sarosh. One more thing is that, if you have a woman who has uncontrolled blood pressure during the embryogenesis period, when she's getting pregnant periconceptionally, that is also been identified as a teratogen to give rise to increased possibilities of congenital heart diseases in the baby. And therefore, if you are looking at the fetal health, it is very important. It's not actually the antihypertensive medicines which are causing this. The hypertension itself is acting as a teratogen. And therefore, we have to control blood pressure the moment we find the record of 140/90. And that is something which is extremely novel and important to not only protect the mother, but also the baby. So anybody would like to comment on the antihypertensive medicines from the panelists? Thank you, Dr. Sarosh, for that wonderful answer. And, so it gives us guideline. And I hope Dr. Tamkin, especially, I look at her with a lot of respect for stillbirth and related issues. And I hope you're happy with the flow of discussions that are going. Dr. Tamkin?
Yeah, really very interesting. And some very important issues resolved here.
Yes, it's possible that we may land up doing only one case, but doesn't matter. I think we are taking more important issues. What do you say, Dr. Latika? Are you in agreement?
Absolutely, ma'am.
Yeah, absolutely. Chalo, let's look at the antihypertensive.
For antihypertensives, ma'am, first, mostly we start with labetalol because nowadays we have difficulty finding methyl dopa, as everyone must have faced. Correct. And initially we used to start the one antihypertensive and go to maximum dose. But this guideline, ISSHP says that we have to start oral medications like labetalol, and we will give, will go till medium dose. And if that BP is not controlled, then we'll add drug with another mode of action. Like we can add nifedipine or methyl or whatever is there. And if that is also, after going to medium dose, if that is also not working, then we'll add third dose. Right, ma'am?
For an asthmatic, do not give labetalol.
Yes, ma'am. Obviously, ma'am. For asthmatic with congenital heart block, with cardiac failure, these things will not give
These
labetalol.
are very important things. I wanted you to bring this around because methyl dopa is not available. We are depending now on nifedipine and lab discussion ahead. So is anybody on the panel would try to give it for the benefit of the delegates and everybody sitting where you will not use labetalol, because that's the first go-to medicine that we are using.
You will not use for an asthmatic. You will check the pulse rate before starting, because suppose you have an undiagnosed block there, you may actually aggravate the condition. So check the pulse rate before you start. And as the other panelists said, heart failures do not give. And it can cause actually hypoglycemia on the baby. So please check out for neonatal hypoglycemia on the baby is delivering, and monitor the sugars of the baby also when the mother is on labetalol.
Maximum dose of labetalol which you have used in your practice, Dr. Charmila?
Mine, I've by the time it crosses this thing, I would have delivered her. But maximum, I've gone up to probably 600, not more. I'll add.
Trying to learn, because
I will add a second antihypertensive rather than increasing my dose of labetalol if it's not getting controlled. That's what. So
after 600 is your second addition of dose?
Yes.
Okay. Anybody else on the panel would like to differ on this?
No, ma'am. Ma'am is very right, because this guideline also says same thing, because we can see that in ACOG guideline it is still 2400 milligram. But
yeah, I was going to say that,
yes,
and I've used that, but I would agree somewhere between 600 to 800. So if you're giving somebody 200 3 times a day and the blood pressures are still high, I typically give the second agent and then I tag team between the two. So then if I add a second agent at 30 and the blood pressure is still high, I increase the labetalol. And if it's still high, increase the nifedipine. I do try to get to both maximum. And then I agree with most of the people here. I mean, you're probably going to end up delivering because of something else that's going on.
Yes,
but ACOG does say up to 2400, and I've used pretty extensive 800 TID is a pretty common dose that I use in my practice.
And you actually alternate between the two therapies.
Like I kind of, yeah. So I add
that
the
works
second
out
dose,
much.
and then I add one, and then I increase the first one, and then I keep the second one the same. And if time comes, I increase the second one and keep the first one the same. And also, like nifedipine, I sometimes give BID. So I start at 30 once a day, and then I very quickly do make it 30 twice a day, and then I make it 60 twice a day. So I'm very, very frequently XL. I'm giving it 2 times a day rather than just once a day.
And sometimes
and this we're talking about like patients better. Yeah, and I think we're talking about patients who are 24 weeks 26 weeks where you really try to get to that latency so you can have like a live baby at the end of it. If you're 32 34 weeks, then obviously your threshold for treating severe hypertension should be in our minds a little bit lower. You don't want to like, you know, already at 34 weeks and try to like, you know, add 15 different agents. So I think some of the, at least in my mind as a clinician, my threshold to treat is at least like, you know, at a very level, I see where the patient is in terms of, you know, her gestational age, how far I'm trying to go. But I'm pretty aggressive though. I try to go as far as I can.
Yeah, one thing.
Yeah, Dr. Pratibha, yeah.
Yes, I just want to add one thing. What we do in our practice, just the moment we see that the blood pressure is not getting controlled with the dose which we are giving, before increasing the dose, we once again check our parameters, specifically the biochemistry, the fetal well-being, and then only we increase the dose or add up the another dose. That's the only thing which I wanted to add.
100% agree. Thank you for pointing that out. Yes, because you don't want to be treating health. Yes, absolutely. So you want to be every time trying to assess whether, you know, she's still a candidate for expectant management. Absolutely.
How many on the panel would like to subject this woman to a maternal to cardiac evaluation?
I will do.
Yes, I think even I will do. How many on the panel would like to do this now? Because you're stepping her antihypertensive medications. I think it's very important that we do a maternal 2D echo, and that will also help us in assessing her else. How many of you would agree to this?
Right now we are not doing it, but maybe we will think about it now.
Yeah, we must.
Guidelines have come up, we'll definitely think about it.
Yeah, it helps us in
Otherwise,
taking
is also associated with a lot of cardiac dysfunction.
Not only that, it will also help us to identify the left ventricular thickness, which can help us in taking care of the mother when we can stop now the pregnancy and deliver her. Secondly, it will also help us in proper fluid management during labor or C-section, whatever we choose to do. And now if you realize, I must share this with all of you here in our country, in the state of Tamil Nadu, even the government facilities are recommending universal 2D echo screening for all pregnant moms at 32 weeks of gestation.
Yes.
I think this is something which is very important and we have to be careful about, because now we are dealing with patients who are older in their age groups. We were, for some time when we had very young moms coming to us, we were a little, sort of their age was their protective armor. But now older women, obese women, diabetic women are coming to pregnancy to us, and therefore we have to be careful and try to look at their cardiac changes also. Yes, Dr. Latika, you can take it from here.
Right. So we've discussed about the drugs that are used in non-severe hypertension. What would be the drug of choice for acute onset severe hypertension? Dr. Richa?
Yes, we have different options, and all drugs are equally effective, like labetalol and nifedipine mostly are the drug of first choice. And hydralazine also we can use, but many times it is very difficult to find hydralazine, as I have seen during my practice. And for labetalol, we'll start with 20 to 40 milligram IV dosing, followed by this 40 to 80, and total maximum of repeating it in every 20 minutes, 20 to 30 minutes, and maximum of 300 cumulative dose. And many times, if we don't have any IV access or something, then advantage with nifedipine is that we can quickly give the medication to the patient by oral route, and it does not need IV supply. So that is the advantage with this nifedipine, and all the three are equally effective.
I would like to add in the same breath immediately while you're saying, but don't give it sublingually.
Absolutely. I was just about to say that, ma'am.
Yes, ma'am.
Dr. Latika, actually, giving oral nifedipine seems more comfortable, even if the hypertension is more. You can monitor, bring it down, and if it's not getting control, then we go for an intravenous dose of labetalol.
Right. So you never give it sublingually, because suddenly the blood pressure is going to crash down, and that's
oral immediate release.
Oral is fine. Yes, ma'am.
Yes, ma'am.
The only thing I would add here, Dr. Charmila, is that when the patient is already on an oral antihypertensive, so patients who are already on labetalol or nifedipine, sometimes what I do is I start with IV hydralazine then, because I don't want to like max out my labetalol, because then you give her IV labetalol and you multiply it by 3 times, so then you're like maxing out your daily dose of your labetalol. So patients are already on one agent. I try to not give the same agent IV. So obviously you're talking about naive hypertension and nobody's on anything. So we typically in our practice start with labetalol. And then I agree with Dr. Charmila that I actually like oral nifedipine quite a bit. It controls the blood pressures really nicely.
Even oral labetalol is equally effective.
Yes, correct.
Oral labetalol is also quite safe. I just wanted to somebody to make a comment on sodium nitroprusside as an antihypertensive in hypertensive crisis, especially in the context of the fetal condition. Sodium nitroprusside.
I've never used it.
Yeah. Sometimes it is used for very refractory hypertension, but it is supposed to be put on guard, because after 4 hours of use, it can cause fetal cyanide poisoning is what has been believed. And therefore, usually we don't turn to these antihypertensive medicines. How about giving magnesium sulfate now in an acute onset severe hypertension?
You should.
So universally, everybody agrees on to this?
Yes.
We all agree.
Absolutely. So you would want to say anything, Dr. Latika?
So yeah, we've been having this discussion. So at the end of the day, what is it that we want? We want to keep the target blood pressure to less than 85, right? And that is irrespective of what the systolic blood pressure is. But if the systolic is more than 160, then either you increase the dose or you add another antihypertensive. So that is what is required.
Hello.
So what are the now this patient's pregnancy is at 32 weeks. and she's admitted with you. Next morning, you are coming in your rounds, and you're asking your residents about the status of the patient, right? So today, what are the indications that you would like to terminate this pregnancy with preeclampsia? So can somebody comment, please? Dr. Priyanka or Dr. Bhumika? Dr. Priyanka?
Okay, so I'd like to say that if the blood pressure remains uncontrolled despite whatever drugs that we are giving, that could be one indication for termination. Or if the patient has signs of worsening disease like persistent severe headaches, which could signify some kind of stress setting in, or persistent severe severe epigastric pain, or visual disturbances, or signs of health if she's going into, or since we're seeing this patient on the rounds, there is no question of convulsions. But if there are other features which suggest fetal compromise, like the non-stress test is reassuring, or if there is reversal of end-diastolic flow on the Dopplers, or it is if there is an intrauterine fetal demise, we're not able to see the cardiac activity.
We actually don't want the intrauterine fetal demise to happen. That's why we want to deliver earlier on.
Yeah, but the indications we're talking about, if we want to terminate this pregnancy, so fetal parameters and the maternal parameters. So if the fetal parameters are going haywire, like the Dopplers or the non-reassuring, then NST, then we would want to terminate. Or there is absolute anhydramnios, or the liquor really drops down, or the biochemistry is suggesting severe worsening of disease, or the maternal parameters are worsening, then we'd like to terminate this pregnancy, maybe.
Right. So we've already had those maternal indications and fetal indications. Either it's anhydramnia or AEDF more than 32 weeks, REDF more than 26 weeks. If you find that the NST is non-reactive and there's poor biophysical profile, that could be some of the indications where you want to deliver the patient today for fetal reasons.
Latika, can I say something?
Yes, Charmila.
So termination will depend on the gestational age of the baby. Suppose it's 37 weeks, there's no point in continuing deliver.
Yes.
Abnormal labs. So your monitoring of the maternal labs are very important. Depending on that, your termination will happen. Depending on the symptoms that the mother develops.
But can we go back to the maternal slide as well?
The symptoms that the mother develops will be the third indication. The fourth will be the abnormal fetal parameters which you see in the surveillance. All this will decide on method of decide whether you're going to terminate her then and there.
So, like already discussed, maternal indications and fetal. We just discussed the slide on fetal. Here again, if the PE is at 37 weeks, deliver. If it's a PE with complication at any time, then you have to deliver. You don't have to wait to take her to 34 weeks or take her to 37 weeks. There's the second thing here on this particular slide.
To point one more thing which I wanted to make a point here. Can I say something?
Yes, ma'am.
Hello.
Yes.
Hello.
Like we were talking of doing maternal surveillance by looking at a cardiac health, it's also important to look at a fundoscopy whenever you have a patient of severe pre.
Absolutely. So papilledema would be an indication.
Yeah,
so sometimes you will need to do a urine analysis and not just your dipstick and confirmation. You can have a underlying CKD also causing that hypertension.
And the second thing is whenever there is REDF, it mentions that more than 70% of the intervenous space is affected. And therefore we have to be look very closely to this baby for stillbirths or IUDs, you know. So if there is REDF, more than 70% of the intervenous perfusion can be affected. So we have to have them under surveillance.
Right, ma'am. So I think maybe we can have Dr. Sarosh comment upon this, give a recommendations for screening of PE in low setup, poor resource country like ours. So,
it's funny because you're saying low setup, even in the US, look at ACOG. ACOG is saying history based. So that's what we are doing, sadly, is we just ask the maternal history, which is obviously not the, not even close to what the FMM guidelines. Yeah. So I think you guys should all follow the Fetal Maternal Foundation guidelines, which is talking about mean arterial pressures and Dopplers and PLGF. And I think that's the best way to assess the maternal, in the first trimester. I don't know what you guys are doing, but either do not follow the ACOG. That's all I can say. I think you should use maternal factors, her history, but also PLGF and MAP. And if nothing is available, MAP and PLGF are. Yes, I mean,
that would be the best case scenario. However,
yes,
ma'am,
so worst case scenario is the history based then. This is what
absolutely.
we can all, yeah.
Right.
I mean, we ask about her prior history and assess her risk factors such as history of chronic hypertension, kidney disease, renal transplant. Those are the patients obviously at significantly high risk, African American race in our patient population, obesity, history of IVF, lupus. Those are our significant risk factors, which are all history-based risk factors. But you know, the problem with history-based risk factors and also prior history of preeclampsia, like everybody knows, is a significant risk factor for preeclampsia and subsequent pregnancy. The problem is that preeclampsia occurs in primiparous women, and a lot of times women have no risk factors. That's why history-based risk factors are actually poor predictors of preeclampsia. Yes, but if you don't have anything, yes, please classify them based on their history, as ACOG classifies them based as severe risk factors, moderate and low risk factors for pregnancy. So severe risk factors are patients with chronic hypertension, kidney disease, type 2 diabetes, history of lupus, kidney transplants. Moderate risk factors is everything else. Your AMA, age more than 35, BMI more than 30. If you have a prior history of term preeclampsia, so prior history of preterm preeclampsia less than 34, 37 weeks is high risk factor. But if you have term preeclampsia, is moderate risk factor. Recurrent preeclampsia in prior pregnancy is also a risk factor, severe risk factor. The only low risk factor is if you have, at least in US, is if you are a white woman. So if you're Caucasian, so non-Black, and you have no prior history of prior preeclampsia, that would be the only person who would be at low risk. So those are the traditional history-based risk factors that ACOG recommends, and then also the US Task Force recommends. And then the reason I'm even bringing this up is I'm sure your next slide is what to do if you classify the patients in the first, second trimester based on their risk factors would be give them aspirin. So US recommends that, yeah, taking aspirin, and we are still saying 81 milligrams. So there's tons and tons of literature that, you know, obviously anything over 100 milligrams should be effective. So please give 100 milligrams of aspirin. I tell a lot of my patients to take 2 doses. So they just take 2 pills, although ACOG says take 1 pill. And yeah, so you give aspirin for patients who are either high risk, so 1 or more high risk factors, or more than 1. So if you need to have at least 2 moderate risk factors. So if you're AMA and higher BMI, if you're low socioeconomic status and higher BMI, so you're African American and higher BMI. So high risk factors only 1, moderate risk factors 2. And the only time you won't really recommend aspirin will be somebody who's at low risk, which is like very small patient population. And here you've written it out. I think the best guidelines are just coming out from that, you know, big paper that was published, the ASPRI trial, which says that we should give 160 milligrams of 150 milligrams of aspirin before 16 weeks. Absolutely.
Right, ma'am. Thank you so much for your valuable input. So the International Society also says that you should, motivate women to exercise in pregnancy. Aspirin, we already know, and calcium when the calcium intake is less. So these are the things. And as far as the other things are concerned, like heparin or vitamin C or folic acid, these things are not to be advised. So the take-home message from these couple of slides is that the best would be you screen them on the basis of history, on the basis of blood pressure, and your ultrasound and the biochemical markers. But sadly, the Indian scenario, we don't have all these. So if you have nothing, at least the history works, and at least combine your history with the mean arterial blood pressure. That is something that almost all the gynecologists should be doing. So
even if you walk for 140 minutes per week, that will reduce 40% of preeclampsia. So walking, exercising, taking folates from diet sources, and as she rightly said, calcium would be very important. And then maybe since we do not have such biomarkers, we should keep them under close surveillance and educate our women why we are doing this close surveillance.
So we've got a 27-year-old priming. She's at 37 weeks period of gestation, and she's been brought to the casualty with a history of 3 episodes of abnormal movements with altered consciousness 15 minutes ago. So the patient is a bit drowsy, although her GCS is 11. Her BP is 170 by 120 and albumin was 3+. The uterus is irritable, and you hear that the fetal cardiac activity is at 140 beats per minute and it's regular. You do a PV, and the cervix is 3 centimeters, soft central vertex, 2 centimeters long, vertex is at -1 and membrane plus, the pelvic is adequate. So how would you proceed with the management of this patient now?
Yeah, the management of eclampsia is you prevent a maternal injury first. The second part will be maintaining her cardiovascular function. For that, airway, breathing and circulation should be secured. and then you'll be giving her to prevent recurrent seizures. You'll be giving her magnesium sulfate. You'll be controlling her blood pressures, and then you'll take a call on delivery of the patient because her GCS score is quite okay, not very bad. You can induce her and then deliver her.
Right, fantastic. So we do the ABCD of the patient, anti-epileptics, anti-hypertensive management, and then we go into the obstetric management. That is, she's already 3 centimeters. We need to augment, and then we need to deliver her.
Absolutely.
Next slide, please. Ma'am, case scenario D. So now the same patient is here, GCS 11. When you listen to the fetal heart, the fetal cardiac activity is 80 beats per minute. So now what would your plan of management be?
Here also it will be the same. You will manage the mother first, stabilize her, then you will go for the delivery. Sometimes the fetal heart rate patterns, even if they are abnormal with the seizure, they return to normal sometimes. Suppose they are not returning and the patient is, if she has gone for an abruptio or the fetal heart rate pattern is very bad, very poor, then probably you'll go for a cesarean section.
But the seizure has happened. So would you like to give her a trial of normal delivery with 80 beats per minute?
No, sometimes that's what I'm saying. During a seizure or sometimes little after the seizure also, the fetal heart pattern may be abnormal. But once a mother is resuscitated, some babies return to normal also. So you can wait. But if it's not returning to normal, you will go for an emergency cesarean.
Girija ma'am, what would be your take on this?
Yeah.
Fetal heart rate pattern is abnormal after a seizure, Girija. So will you wait or you'll go for an emergency cesarean?
When she has a convulsion.
She's had
no, we wait,
3
because
convulsions.
during the convulsion, the fetal heart rate becomes unstable for 20 minutes. You keep the patient well oxygenated. Don't allow that seizure-related decision to make you do an emergency C-section without stabilizing the mother.
Yeah, but then she's had 3 episodes, ma'am. She's had 3 episodes of seizures, and then she's been brought to the hospital.
We are going to deliver her, but we can deliver. We can definitely 3 episodes of C-section if her and if a GCS score is bad, then we can consider doing a C-section, but then not with a blood pressure of 170, 120. And
Girija, she wants to know, like, if the fetal heart rate pattern is abnormal during a seizure or little after the seizure, will you go for an emergency?
You have to give her 20 minutes time because usually it recovers after that. But then if the baby is a very sick baby, it may also cause abruption and an IUD. So that also we have to keep a watch on.
Can I interrupt?
Yes.
I just, about 5 minutes back, I got a message from the digital partner that this, Zoom meeting will finish in another 15 minutes.
Okay.
So I think Dr. Revathi and Dr. Sarosh has to give the concluding remarks as well as the vote of thanks by Dr. Inaz, and Dr. Revathi would like to talk about PenI initiative. So I think I'm sorry, it was so interesting.
No problem at all.
Right, ma'am, we would like to end the panel. Thank you.
Thank you. We would like to thank you all for giving us this time, and put your hands together to all the panelists for wonderful inputs. Thank you so much.
Thank you so much, ma'am.
Thank you, Latika. Thank you, Latika and Girija.
Thank you so much, ma'am.
Thank you, everyone.
Thank you, Dr. Girija and Dr. Latika. It was indeed a wonderful panel. Very good discussion, lot of practical tips and take-home messages. And now I would like to request Dr. Sarosh Rana to give her concluding remarks. We have already heard her excellent inputs during the panel and would love to hear from her once again. Sarosh Rana, ma'am, please.
Thank you so much. I don't know how much time we have, Tamkin ma'am, because I do want Revathi to talk about PenI. So I prepared a little speech, but I'll maybe just let go of it and just say thank you to everyone. Thanks, Dr. Tamkin ma'am, for inviting me, and thanks for the organizers. It's like really great. So Tamkin ma'am was my residency director when I was a resident at JNMC. So she's been really kind for the whole, pretty much for the past, literally 30 years. One thing I wanted to say is that perhaps one thing that maybe I can leave everybody with a thought, and I know you guys are practicing in rather difficult situations, and sometimes even I'm practicing in rather difficult situations. But maybe I just got this quote that whenever we feel disheartened, even progress seems too slow, and whenever it seems that challenges are too much, we should just remind ourselves what we are doing. So I think every time, you guys were having the discussion about eclampsia, and every time I see an eclamptic, I just really truly believe that it can be prevented. So here in the context of IUFTs, we just have to really see each patient with all our heart and make sure that, obviously these kind of conferences are amazing to just disseminate knowledge. So thank you for really just thanks for making me the part of this really wonderful conversation today.
Thank you, ma'am. And now I'd like to request Dr. Anjoo to summarize and give us some take-home messages. Anjoo, ma'am, please.
Thank you, Seema. And it has really been a scintillating case discussion, and we were really enjoying it. It has been a global discussion with inputs from USA, from UK, from Vinita, and all our stalwarts in India. Some of the important points which I think which we can take home with us, there's really a role of SFLT PLGF ratio. And as I was seeing in the chat box, Dr. Eti said it is costing only 5,500. So to save a maternal and neonatal life, that is not a big cost. So we can consider using it in a routine practice, which we have not been doing so far. Another very important take home was to start antihypertensives, even at 140 by 90 millimeters of mercury. All our experts agreed on that. And the choice of antihypertensive definitely was the same as we are following, but it helps to improve the maternal outcomes and maybe has a role in preventing fetal teratogenicity. The importance of admitting all women diagnosed with preeclampsia for the initial workup to classify their disease as having severe or not having severe features, and to do a steroid coverage is again very important. And that 48 hours admission is going to go a long way to saving our mothers and babies. So it has been a very fruitful discussion, and we have many take-home points, and I'm sure all of us have enjoyed it.
Thank you, ma'am. Thank you for summarizing those valuable practice points, and hope it will help us in our practice, daily practice. So thank you so much.
Good evening, everyone. On behalf of the organizing team, it's my proud privilege to propose a vote of thanks on this occasion. First and foremost, I would like to specially thank our guest of honor, Professor Sarosh Rana, for not only sparing her invaluable time, but also enlightening us with a commendable talk on the subject, the role of antihypertensives and management of the patients in general with hypertensive disease. I extend my gratitude to our distinguished speaker, Dr. Revathi Rajan, for an interesting and highly informative presentation with the role of biomarkers for predicting severe preeclampsia and introducing us to PENAI initiative. I may like to express a sincere thanks to Dr. Seema Mehrotra, Dr. Girija, and Dr. Latika Chawla for excellent coverage of the topic. I'm very grateful to all esteemed panelists and delegates of the webinar for their presence and contribution. My profound gratitude to Professor Agarwal, chairperson of the committee, for organizing the webinar and making this event a grand success. A special thanks to Professor Tamkin for her logistic support and guidance throughout. Finally, I would like to thank each and every one of you being here and actively participating in the webinar. Thank you, everyone, once again. Thank you.